8 Amlodipine skin side effects your doctor might not warn you about. If you're one of the millions of people who take amlodipine to keep your blood pressure in check, you know it's a fantastic, life-saving medication. But have you ever wondered about those other, lesser-known effects? The ones that show up on your skin. Welcome to today's medical education video about amlodipine skin side effects. Amlodipine belongs to a class of medications called dihydropyridine calcium channel blockers, primarily prescribed for managing hypertension and chronic stable angina. While this medication effectively controls blood pressure by blocking calcium channels in vascular smooth muscle cells, it can trigger various dermatological reactions that patients and healthcare providers must understand. Research published in the International Journal of Dermatology indicates that amlodipine-induced skin reactions typically manifest within the first 2 to 8 weeks of treatment initiation. Delayed reactions can appear months after starting therapy, ranging from mild and self-limiting to severe and requiring urgent care. Recognizing potential skin complications early helps patients and healthcare providers manage them promptly through dose adjustments or medication changes. Today, we'll explore 8 specific skin side effects associated with amlodipine use, examining their clinical presentation, underlying mechanisms, and management strategies based on current medical research and clinical guidelines. Disclaimer: this video is for educational purposes only and is not intended as medical advice. Always consult a licensed healthcare professional regarding any questions or concerns about your health, medical conditions, or treatment options. All information presented has been thoroughly researched and verified. You can find source links in the video description. 1. Maculopapular rash, raised red skin lesions. Maculopapular rash occurs in approximately 1.2% of amlodipine users, as reported in the Journal of the American Academy of Dermatology. This skin reaction presents as discrete red spots, macules, combined with raised lesions, papules, creating a characteristic mixed appearance. The rash typically begins on the trunk and spreads symmetrically to the arms and legs, rarely affecting the face or mucous membranes. The pathophysiology involves amlodipine acting as a hapten, a small molecule that binds to skin proteins, creating new antigenic complexes. These complexes trigger type 4 delayed hypersensitivity reactions mediated by T lymphocytes. Research in clinical and experimental dermatology shows that the reaction typically develops 7 to 21 days after treatment initiation, consistent with the time required for T-cell sensitization and proliferation. Histopathological examination reveals perivascular lymphocytic infiltration in the upper dermis, with occasional eosinophils present. The Journal of Investigative Dermatology published findings showing increased expression of inflammatory cytokines, particularly interleukin-4 and interferon gamma, in affected skin biopsies from amlodipine users. The rash may be accompanied by mild pruritus in 60% of cases, though severe itching is uncommon. Dermatology Online Journal reports that the eruption typically resolves within 2 to 4 weeks after amlodipine discontinuation, leaving temporary post-inflammatory hyperpigmentation in some patients. Rechallenge with amlodipine usually results in rash recurrence within 2 to 5 days, confirming the drug-specific nature of the reaction. Topical corticosteroids may accelerate resolution but are not always necessary for mild cases. 2. Urticaria, allergic hives formation. Urticaria, commonly known as hives, affects approximately 0.8% of patients taking amlodipine, according to data from the Journal of Allergy and Clinical Immunology. This reaction presents as raised, erythematous wheals with well-defined borders, often accompanied by intense pruritus. The lesions typically appear suddenly and may change location and size over hours, a characteristic feature distinguishing urticaria from other drug eruptions. Amlodipine-induced urticaria results from mast cell degranulation triggered by drug-specific IgA antibodies or direct histamine release through non-immunologic mechanisms. Research in the International Archives of Allergy and Immunology demonstrates that both pathways can occur, with IgE-mediated reactions showing positive skin tests to amlodipine in specialized allergy centers. The reaction typically develops within 1 to 6 hours of drug administration in sensitized individuals. Clinical presentation varies from localized wheals affecting small skin areas to generalized urticaria covering large body regions. The Annals of Allergy, Asthma and Immunology reports that chronic urticaria may develop in some patients, persisting for weeks to months even after amlodipine discontinuation. This prolonged course suggests ongoing immune activation beyond the drug's elimination half-life. Severe cases may progress to angioedema, involving deeper skin layers and mucous membranes. The Journal of Emergency Medicine documented cases where amlodipine-induced urticaria was accompanied by facial swelling, particularly affecting the lips, eyelids, and tongue. Such presentations require immediate medical attention and epinephrine administration if respiratory compromise occurs. 3. Pruritus, intense skin itching. Pruritus, or pathological itching, affects approximately 2.1% of amlodipine users according to data from the International Journal of Dermatology. This side effect can occur as an isolated symptom or accompany other cutaneous reactions, significantly impacting patient quality of life and treatment adherence. The itching typically presents as a generalized sensation without visible skin changes, though secondary lesions may develop from scratching. The mechanism underlying amlodipine-induced pruritus involves multiple pathways including histamine release from mast cells and activation of itch-specific neural pathways. Research in the Journal of Neuroinflammation demonstrates that calcium channel blockers can influence nerve fiber sensitivity in the skin, lowering the threshold for itch sensation. Additionally, amlodipine's vasodilatory effects increase skin blood flow and temperature, both factors known to enhance pruritic sensations. Clinical presentation varies from mild, intermittent itching to severe, persistent pruritus interfering with sleep and daily activities. The Journal of Clinical Pharmacy and Therapeutics reports that elderly patients show higher susceptibility to amlodipine-induced pruritus, possibly due to age-related changes in skin barrier function and reduced sebaceous gland activity. The condition typically develops within the first 4 to 8 weeks of treatment. The pruritus often shows circadian variation, typically worsening in the evening and at night. Treatment approaches include antihistamines for symptomatic relief, though the most effective intervention remains dose reduction or drug substitution. Topical cooling agents and moisturizers may provide temporary relief, but definitive resolution usually requires amlodipine discontinuation. 4. Flushing, vasodilation-induced skin redness. Flushing represents the most common cutaneous side effect of amlodipine therapy, affecting approximately 4 to 8% of patients according to data from the American Journal of Cardiology. This reaction manifests as sudden episodes of skin redness, warmth, and sometimes burning sensations, typically affecting the face, neck, and upper chest regions. The phenomenon occurs due to amlodipine's primary mechanism of action, calcium channel blockade in vascular smooth muscle. When amlodipine blocks L-type calcium channels, it prevents calcium influx into smooth muscle cells surrounding blood vessels. This blockade causes arterial and arteriolar dilation, particularly in cutaneous vessels. The Journal of Cardiovascular Pharmacology reports that skin blood flow can increase by 40 to 60% during flushing episodes, creating the characteristic red appearance. Flushing episodes typically last 15 to 30 minutes and may be triggered by physical exertion, emotional stress, or consumption of hot beverages or spicy foods. The Hypertension Research Journal documented that women experience flushing more frequently than men, possibly due to hormonal influences on vascular reactivity. Postmenopausal women show particularly high susceptibility rates. Clinical studies in cardiovascular drugs and therapy demonstrate that flushing intensity often correlates with serum amlodipine concentrations. Patients taking higher doses, 10 mg daily, report more frequent and intense episodes compared to those on 5 mg daily. The reaction typically diminishes over 4 to 6 weeks as vascular tolerance develops, though some patients continue experiencing symptoms throughout their treatment course. 5. Contact dermatitis, inflammatory skin reaction. Contact dermatitis represents an uncommon but clinically significant adverse reaction to amlodipine, documented in approximately 0.3% of users according to Contact Dermatitis Journal publications. This reaction manifests as localized inflammation characterized by erythema, vesiculation, and scaling in areas of direct skin contact with the medication or its metabolites. The condition typically develops through allergic contact dermatitis mechanisms rather than irritant pathways. The pathophysiology involves amlodipine or its metabolites acting as contact allergens, binding to Langerhans cells in the epidermis. These antigen-presenting cells migrate to regional lymph nodes where they activate T helper cells, initiating a delayed-type hypersensitivity response. Research published in Dermatitis Journal shows that amlodipine metabolites, particularly those formed through cytochrome P450 metabolism, may possess greater sensitizing potential than the parent compound. Clinical presentation includes acute eczematous changes with erythema, edema, and vesicle formation in sensitized individuals. The American Journal of Contact Dermatitis reports that the reaction typically appears 24 to 72 hours after exposure, reaching peak intensity within 96 hours. Chronic exposure may lead to lichenification and hyperpigmentation of affected skin areas. Diagnosis requires patch testing with amlodipine and its known metabolites, performed by specialized dermatology or allergy centers. The European Contact Dermatitis Society recommends testing concentrations of 1% and 5% amlodipine in petrolatum for accurate sensitivity detection. Positive reactions typically appear as erythema and infiltration at 48 to 96 hours post-application. Treatment involves topical corticosteroids for inflammation control and strict avoidance of calcium channel blockers in the dihydropyridine class due to potential cross-reactivity. 6. Erythema multiforme, target-like skin lesions. Erythema multiforme represents a serious cutaneous reaction to amlodipine, occurring in fewer than 0.1% of patients but requiring immediate recognition due to its potential severity. This condition presents with characteristic target or bullseye lesions, typically measuring 1 to 3 centimeters in diameter with central dusky areas surrounded by pale rings and outer erythematous borders. The Journal of the American Medical Association has documented several cases linking amlodipine to erythema multiforme development. The pathogenesis involves immune-mediated destruction of keratinocytes through CD8+ T lymphocyte activation. Research in the Journal of Investigative Dermatology reveals that amlodipine can trigger this response by altering keratinocyte antigen presentation, leading to autoimmune-like attacks on skin cells. The reaction typically develops 1 to 3 weeks after treatment initiation, though delayed presentations have been reported. Clinical manifestations include symmetric distribution of target lesions, predominantly affecting the extremities and face. Histopathological examination reveals interface dermatitis with basal keratinocyte necrosis and lymphocytic infiltration at the dermal-epidermal junction. The Archives of Dermatology published findings showing increased apoptotic keratinocytes and satellite cell necrosis in amlodipine-induced cases. The condition typically resolves within 2 to 4 weeks but may leave post-inflammatory hyperpigmentation. Patients should avoid all calcium channel blockers due to potential cross-reactivity within the drug class. 7. Alopecia, drug-induced hair loss. Alopecia represents an uncommon but distressing side effect of amlodipine therapy, reported in approximately 0.2% of patients according to the Journal of the American Academy of Dermatology. This hair loss typically presents as diffuse thinning rather than patchy baldness, affecting the scalp primarily but occasionally involving eyebrows and other body hair. The condition usually develops 2 to 6 months after treatment initiation, reflecting the hair growth cycle's natural timing. The pathophysiology involves amlodipine's interference with calcium-dependent processes essential for hair follicle function. Research published in the Journal of Investigative Dermatology demonstrates that calcium channels play crucial roles in hair follicle cycling, keratinocyte proliferation, and hair shaft formation. Amlodipine's calcium channel blocking properties may disrupt these processes, pushing hair follicles into premature telogen, resting, phase. Clinical presentation typically involves gradual hair thinning noticed during shampooing or brushing, with increased hair counts on pillows and in shower drains. Dermoscopic examination reveals decreased hair density with uniform diameter reduction across affected areas. Microscopic analysis of affected hair shafts shows structural abnormalities including decreased diameter and premature keratinization. Recovery typically begins 3 to 6 months after drug discontinuation, with complete restoration possible in most cases. Topical minoxidil may accelerate regrowth, though its use should be coordinated with cardiovascular management needs. 8. Purpuric eruptions, bleeding under the skin. Purpuric eruptions represent a rare but serious dermatological complication of amlodipine therapy, documented in fewer than 0.05% of patients according to blood coagulation and fibrinolysis journal reports. These lesions appear as non-blanching purple or red spots caused by bleeding into the skin from damaged capillaries or platelet dysfunction. The condition requires immediate medical evaluation due to potential underlying hematological complications. The pathogenesis involves amlodipine's effects on platelet aggregation and vascular integrity. Research in thrombosis and hemostasis demonstrates that calcium channel blockers can impair platelet function by reducing intracellular calcium availability necessary for aggregation and clot formation. Additionally, the drug's vasodilatory properties may increase capillary fragility, predisposing to spontaneous bleeding under normal pressure conditions. Clinical presentation includes petechiae, pinpoint purple spots, and larger purpuric patches, typically appearing on dependent areas such as legs and feet initially. Laboratory evaluation often reveals normal platelet counts but impaired platelet aggregation studies. Histopathological examination shows extravasated red blood cells in the dermis without significant inflammatory infiltrate, distinguishing it from vasculitic purpura. The Journal of Cutaneous Pathology published cases showing endothelial swelling and basement membrane irregularities in affected vessels. Treatment requires immediate amlodipine discontinuation and hematological evaluation to rule out thrombocytopenia or coagulation disorders. Alternative antihypertensive agents from different drug classes should be selected for ongoing cardiovascular management. Subscribe to the Human Health YouTube channel for more insights. If you found this content helpful, please like, share, and comment below.